right, so maybe we'll get started. So how many people went to Grand Rounds yesterday? Okay, great. It's disappointing that more people didn't show up to Grand Rounds. This was somebody who's made a seminal discovery understanding the pathogenesis of kidney disease. So in preceding years, we had almost a full turnout, and that was probably because I said there would be one bonus question on the exam for this, and it was unbelievable the difference. So you guys were the subject of an experiment. And I guess going forward, we will have that bonus question, that little bit of incentive to encourage people to visit Grand Rounds and learn a little bit more. Okay, so today we're going to talk about genetic and secondary causes of hypertension, or as Dr. Bombach said, identifiable causes of hypertension. The reason why these are important is that most of the cases of hypertension that we're going to encounter are what we call primary or essential hypertension, and we're just going to treat them very generically. In a subset of these individuals, there's a reversible cause, and so if you identify them, you can potentially treat them or cure them of their hypertension. So it's important to be aware of these possibilities, and moreover, in terms of the lecture and learning the material, this is really going to be a review of the mechanisms of volume homeostasis and the neurohormonal regulation of blood pressure. And so from that purpose, I think it is also very useful to review this topic. So you saw this yesterday. Blood pressure goes up with age. The systolic blood pressure really goes up consistently. Diastolic blood pressure starts to dip in older age, mostly because we develop stiffer arteries and the pulse pressure increases. This is what happens in most of Western society, where we are all on a very high salt diet. As Dr. Bombach explained yesterday, the Amazon tribes that are on a very low sodium diet, this age-related rise in blood pressure really does not exist. And so this really underlies and emphasizes the relationship between chronic salt intake and development of hypertension. Let's start with the case presentation. A 40-year-old male who's presenting for a work physical after a long mission abroad. He's gained about 15 pounds over his ideal weight. That's what happens when sometimes you travel and you're out of your regular lifestyle. His blood pressure is high, 160 over 90. His physical and labs are otherwise normal. You ask him a little bit more. His diet consists of eggs fried with half a pack of butter. He eats that every day. He smokes 60 cigarettes a day. He drinks 60 to 70 ounces of spirits a day. He complains of occipital headaches in the morning. He also tells you that he has a stressful job. We all know this patient. Do you know who he is? It's 007. So if you read, they left this part out of the movies, but if you read Thunderball, you will see that this is what's described. This is the intro to Thunderball. This is 007 presenting with all of his, issues. And so he's not and he may be very buffed on the screen, but inside he's got many problems. And so what is he in for? What are some of the issues that he's going to be at risk for? Well, he's going to be at risk for stroke, coronary heart disease, left ventricular hypertrophy, congestive heart failure, end-stage kidney failure, peripheral vascular disease. And so these are the graphs that are, and this is showing the risk of end-stage renal disease since with concomitant hypertension at different stages. And there's essentially a really strong correlation with developing all these cardiovascular and renal complications. And so this tells you basically that all the villains in the James Bond films, instead of finding intricate ways of trying to kill James Bond, they should just buy him a drink and let him smoke his cigarettes, and that's what's going to get him. And in fact, James Bond was modeled after the author Ian Fleming, who was a heavy smoker and drinker and didn't pay much attention to his diet, and he died of heart disease at the age of 56. So we can control all of this and reverse all of these things, and so we just have to be aware of this. What are some of the reversible causes of hypertension or environmental risk factors for high blood pressure? Well, alcohol intake. This is a big epidemiological study. Is looking at over 40,000 men and women enrolled in the studies. These are seminal studies called the Women's Health Study and the Physician's Health Study that have been going on for about 20 years, following the lifestyle and sort of the metabolic and cardiovascular parameters, cancer risk in a large number of physicians, nurses across the country. And so this is the association between alcohol intake per week and the risk of high blood pressure. Well, it turns out that if you're a man, after you adjust for all the other concomitant risk factor, if you drink more than 4 or 5 drinks a day for a week, then you're at much higher risk, and statistically higher risk of developing high blood pressure. If you're a woman, that risk doesn't seem to exist. So that doesn't mean that you can't, this is over a large population, of course. Individually, there's going to be some people who are going to be very sensitive to alcohol. And so you have to ask this question to your patients in the clinic. If they are drinking more than a couple of drinks a day, probably more than a drink a day, and they are hypertensive, then that's something that you can have them stop, and you could see that there's going to be a change in their blood pressure. Okay? So important to notice. The other thing you notice is that many of these epidemiological studies, when you're looking at risk factors for early death or bad things that can happen to you, men seem to have that a lot more and get that a lot more than women. So women appear to be protected, and that's also reflected in the epidemiology. Men tend to die about 10 years earlier than women. The other reversible risk factor for high blood pressure is weight. So as you gain weight, then the risk for hypertension increases. This week we were reviewing in our Renal Journal Club a paper which described how this hormone that's responsible for satiety called leptin, you will hear about this, may be responsible for regulating and the incidence of hypertension in obese individuals. What you see here is the results of bariatric surgery or gastric bypass surgery in morbidly obese individuals. And what happens after you perform this procedure, and to the remission of a number of complications of obesity, such as diabetes, dyslipidemia, high cholesterol levels, HDL, LDL, and then hypertension. And so up to 40% of individuals are completely cured of their hypertension, and they have remission of their hypertension after they lose weight. You note that at the same time, about 12% of people develop high blood pressure during the follow-up period. So there are competing risks, and there are a number of different factors that are involved in the development of disease, yet some people are going to be very sensitive to this. And in patients who are very obese, then that's the first thing you're going to ask them to do, is get them to lose some weight. A lot of drugs out there that can cause high blood pressure. You need to get a good history. And among them, the non-steroidal anti-inflammatory agents, they're responsible. Remember, prostaglandins cause vasodilation and natriuresis. And so this is a very important set of drugs to ask about in your patients. If they are taking NSAIDs regularly, then that may exacerbate blood pressure or may prevent your antihypertensive agents from working properly. We'll go through a list of these, but essentially all of these pathways are the same pathways that we will encounter as we look at genetic and secondary forms of hypertension. Let's talk about salt. The definitive experiment, I think, was done back in 1995 when we looked at our closest cousins, the chimpanzees. This is an experiment where they put chimpanzees on a high salt diet for a period of up to 3 years. And look at the blood pressure of the experimental group. They started at a lower blood pressure, and they wind up becoming hypertensive after 3 years, whereas the control group had normal blood pressure. Chimpanzees eat fruits and vegetables, and they're on a very low salt diet. So they're sort of like the Amazon tribe that Dr. Baumbach described yesterday. And this is reversible in these individuals after 3 years, after you put them back on their regular diet. So a very strong experiment. We can't do this for 3 years in humans. We're all on a high salt diet in a way. We're all taking 3 to 5 grams of salt every day. And so, we're all developed this age-related rise in blood pressure. You can do this in a short term, and this experiment was done in a group of 8 men with average age of 32. And they were placed on a sodium diet of 10 milliequivalents, 300 milliequivalents. So that's about double what we normally take, then 800, and then they were hospitalized, and then they were placed on 1,500 milliequivalents of sodium. Look what happened. They gained on the average of 5.5 kilos, so roughly about 11 pounds over this period of time. This is just salt and water, right? And look at their blood pressure. Their blood pressure rises, their mean arterial blood pressure rises significantly. Look at their urine sodium. We talked about input and output. These were escalated every 3 to 4 days. And you can see their kidneys are really trying to excrete the amount of salt that was given to them. And they try to come into balance. But as you remember, the kidneys takes a little bit of time for it to catch up. So at each point, there's a net salt gain, and that's reflected in their weight at the end of the experiment. And look at their cardiac output. It goes from about 5 liters per minute to 7.3 liters per minute. So about a 40% increase in their cardiac output. Okay. Look at their heart. This is at baseline, and these are 32-year-olds. There's a significant increase in the cardiac diameter. So this reflects the increased intravascular volume. So this I think is another really great experiment demonstrating that the relationship between salt intake and elevation of blood pressure. So there's only so much we're able to accommodate, and the kidney tries very hard, and the vasculature tries very hard to vasodilate, but chronically this is essentially seems to be a losing battle. And so the mechanism of volume regulation, this is, if you increase salt intake, you increase extracellular fluid volume, you increase cardiac output, blood pressure increases. Now you shut down the renin-angiotensin system, you increase ANP. At the same time, remember there's a pressure-natriuresis relationship. As you raise blood pressure, or there are additional mechanisms that are activated in the kidney, independent of the renin-angiotensin system. These we don't quite understand as well. But these all combine together to try to increase salt excretion and to reduce extracellular fluid volume so that we can normalize blood pressure. In the short term, the physiological regulators, when you think about blood pressure, you're talking about cardiac output times the peripheral resistance, right? This is from your cardiology rotation. In the short term, the regulation is in the sympathetic system, in your CNS, in your baroreceptors, okay? You get humoral factors. In the long term, it's really your kidney and your regulation of salt intake that's important for maintenance of blood pressure. The difficulty in trying to study the primary mechanisms that initiate the development of hypertension is that over a long term, the hemodynamic profile looks the same in people who have hypertension from many different primary etiologies. The reason for this is simple. When you start having increased salt reabsorption and increased volume delivery to the heart and increase your cardiac output, you have normal systemic vascular resistance, and that's what leads to increased blood pressure. Over a long term, when this is maintained, there is a phenomenon called autoregulation of blood flow. You've heard about this and learned about this also during your cardiovascular rotation, where you wind up increasing systemic vascular resistance, you normalize cardiac output, and now you have a situation at steady state where you have increased blood pressure with increased systemic vascular resistance. And so no matter how you start out with this increased salt reabsorption and the development of hypertension, over a period of years, this is the hemodynamic profile. So it's very tough to figure out what's initiated the process of increased salt reabsorption or vasoconstriction in the first place. This is a wiring diagram that's from the early 70s, made by Arthur Guyton, who's one of the giants in physiology. There's a textbook, there's still a Guyton's textbook of physiology out there. And so here he was trying to draw a diagram of all the regulatory pathways that are important for maintenance of blood pressure. And you could see already, 50 years ago, we already knew a lot about regulation of blood pressure. And this was taken as evidence that because there are so many different factors involved in regulation of blood pressure, there's no way that you can perturb any one pathway which could result in sustained high blood pressure, because there are so many countervailing mechanisms. Nonetheless, this turned out not to be true. This predicts just we have all these homeostatic mechanisms to regulate and fine-tune blood pressure. There are some critical pathways that can be perturbed and can lead to sustained high blood pressure. Okay? So we talked about the issues, and of course there are all these genes, environment, and demographic factors that interplay, that interact together to lead to the development of disease, and each one of them need to be taken into account. So the question really is, are there situations where there's a single perturbation in your homeostatic pathway which can lead to extremes of blood pressure, whether very high or very low blood pressure, that can inform us about the primary physiology and maintenance of hypertension? And these are the secondary forms of hypertension. We can think about heritability in genetics. I'm putting here the examples of a sport that's my favorite sport, tennis. These are the Bryan twins that are the #1 tennis players in the world. They're monozygotic twins. And so you would think that they're perfect in terms of their sort of concordance for many traits, physiological or racket skills. But it turns out, I think one of them, this is Bob, this is Mike. Bob is about an inch taller than Mike. He's also left-handed. Mike is right-handed. And so this tells you right away that height and handedness are not perfectly genetic, and so there must be additional factors that are involved. And so if you want to look at people who are twins, or people who share half of their chromosomes, this is Serena and Venus Williams, you're going to be able to determine whether they're going to share how much similarity there is in their various physiological parameters. And so based on this, you can determine how much is genetic, how much of it might be environmental. In other words, you can also look at some mean of some traits that you have, let's say blood pressure or height, and if everything was perfectly genetic and we inherited half of every trait, essentially half of each dosage from our parents, then we'd be at the midway average for this, which is the perfect slope. On the other hand, there's going to be the slope of 1, essentially, in blue. On the other hand, there are a lot of traits that are not perfect, and so that tells us that not everything is genetic. And so in terms of looking at heritability, you can look at your total cholesterol level. That's very highly heritable and genetically determined. Blood pressure is somewhat genetically determined. There's going to be a lot of different factors that go in, particularly, again, your salt intake. So let's talk about some of the specific cases that are going to inform us about the pathogenesis of hypertension. A 6-week-old infant, blood pressure 240 over 120. Is that high or low? High. Okay, good. So we're off to a great start. Half the family members have early onset severe hypertension. Others are normal. There's death from stroke before the age of 45, which is very common in this family. When you look at their physiological parameters, you measure renin, it's low. They have very high aldosterone, okay? And what's really peculiar about this particular patient and other affected individual in the family is that the hypertension is reversed by administration of a corticosteroid. So let's think about the physiology of this. You have a situation where you have, what stimulates aldosterone? Renin. And so here you have a situation where you have suppressed renin, but you have elevated aldosterone. So what does that tell you in some ways? You have dysregulated renin, aldosterone secretion, right? Because renin is this normal physiological regulator, yet you still have, and it's low, yet you still have high aldosterone. So something else must be responsible for this persistently elevated aldosterone levels. So if you look at the pedigree pictures, this is multiple generations. The squares are males, the circles are females. The folks, and you can see their blood pressure, you can see a wide range of blood pressure, and you can see people who have a mutation in a gene. And what is the mutation in this family? You have aldosterone synthase and 11 hydroxylase that are two enzymes that are highly homologous and arose by gene duplication. They have two different functions. Aldosterone synthase is important for aldosterone synthesis. 11-hydroxylase is important for the generation of glucocorticoids in the zona fasciculata. This is expressed in the zona glomerulosa of your adrenal glands. And so what happens, because there's a lot of homology between their sequence, you can sometimes have during meiosis an error, and you can have an unequal crossover, resulting in the creation of a chimeric gene. So these individuals have an additional gene, which is a chimeric, that has the 5' regulatory element from 11-hydroxylase and the 3' sort of functional elements of aldosterone synthase. And so from basically this genetic structure, you can imagine, you can predict that basically you have a new gene that's going to have aldosterone synthase activity, but will be under physiological control of glucocorticoid, of the glucocorticoid homeostatic pathway. And so this is really what happens in these individuals. Aldosterone is made in the zona glomerulosa by aldosterone synthase. This is where the gene is expressed. The other gene is expressed in the zona fasciculata, and you will learn about this in the next block. Basically, your cortisol synthesis, which is a glucocorticoid, is under the response of ACTH, which is tonically produced by your brain, by your pituitary and your hypothalamus tonically at night, and is responsible for regulation of aldosterone, whereas angiotensin II and renin is responsible for aldosterone regulation. And so when you have this mutation, now you have a chimeric gene that has aldosterone synthase activity expressed in the zona fasciculata under the control of ACTH. And so ACTH is not suppressed by high aldosterone levels, okay? It's suppressed by cortisol. And so you continue to have excess aldosterone production without a feedback mechanism, essentially. And so these patients develop hypertension. If you give them cortisol, now you start to suppress ACTH, and you reduce aldosterone, ectopic aldosterone production in the adrenal gland, and you normalize blood pressure. Okay? Here's an 18-year-old girl who presents with a blood pressure of 182/100, high blood pressure. Her parents have normal blood pressure, but as you ask them a little bit more, they are first cousins. There's metabolic alkalosis and hypokalemia. You will cover these regulation of acid-base balance and potassium very soon. In this situation, you have low renin and low aldosterone. So these two seem to be aligned here today. Yet the blood pressure is really difficult to control. And there's evidence of left ventricular hypertrophy, and in fact, the patient suffers a cerebellar infarction, so they have a stroke essentially by age 5. What's interesting is that the patient has high urinary cortisol level. So what does that tell you if the parents are first cousins? What are the possibilities that come to mind? Recessive disorders, right, very good. So the first cousin marriages are essentially, you can have situations where essentially each parent inherits one mutation from a common ancestor, and when people intermarry, there's a 25% chance that their offspring is going to wind up with 2 copies of the defective allele, and they may develop a genetic disease. And this is really what's going on in this family, in this individual. This is the principal cell in your cortical collecting duct, where you have the epithelial sodium channel that's under the regulation of aldosterone, which activates the mineralocorticoid receptor and then results in sodium reabsorption through the epithelial sodium channel. Now at the same time, we have cortisol in the blood. Cortisol would be normally an agonist as well for the mineralocorticoid receptor, except that in the kidney we have this enzyme called 11-beta-hydroxysteroid dehydrogenase 2, which converts cortisol to cortisone, okay? And cortisone cannot activate the mineralocorticoid receptor. And that's how the kidney protects itself from the mineralocorticoid action of cortisol or glucocorticoids. What happens in these patients is that they have a mutation, essentially the homozygous loss of function in this enzyme, so they can no longer convert cortisol to cortisone. And so now you have cortisol, again, that's activating the mineralocorticoid receptor. This is not regulated by your by renin-angiotensin system. Even though you can suppress renin and aldosterone, you're still going to have continued stimulation of the mineralocorticoid receptor, and so you're going to have increased salt reabsorption via the epithelial sodium channel. So at the end of the day, this is the mechanism between the first disease, which is called glucocorticoid-remediable aldosteronism, and this one, which is called apparent mineralocorticoid excess, okay, is the same, which is you start to activate your mineralocorticoid receptor, whether because you have excess ectopic aldosterone production, or because you have a ligand now that shouldn't be there, that activates the mineralocorticoid receptor, and that acts in the cortical collecting duct to increase sodium reabsorption, resulting in volume expansion. And the correlate to this is as you reabsorb sodium here, you also excrete more potassium and hydrogen, and these patients have hypokalemic, and they also have alkalosis. We're going to cover this in future lectures. So Here's another case, 54-year-old male who presents with resistant hypertension. He still has elevated blood pressure on 3 drugs, including a diuretic. He also has hypokalemic metabolic alkalosis. He has suppressed renin and aldosterone. So he really looks like the patient, the young girl who had elevated blood pressure, right? Except that this is a 54-year-old guy who's developed hypertension fairly recently in the last few years, he tells you. As part of his history, he reveals he's a flight attendant and he likes to eat copious licorice candy that he buys in England. Who likes licorice? Yes. Okay, so you got to be careful where you get your licorice, because most of the licorice we buy in the United States doesn't have the active ingredient, glyceric acid. I always struggle with this. And so the reason why this patient has hypertension is that they're eating licorice candy that contains this basically glyceric acid. And this is essentially inactivates 11-beta-hydroxysteroid dehydrogenase 2. And essentially works, by doing this, acts by the same mechanism as the patient who has the mutation in this gene. So if you inhibit this, again, cortisol can start to now stimulate your mineralocorticoid receptor, resulting in salt-sensitive hypertension. And that's the reason why this patient had hypertension. Told him to stop eating licorice, and the blood pressure actually normalized. So this is so we should. It sounds crazy to ask your patients about their dietary intake and licorice. We always say, well, this is really out of the blue, and this is looking for zebras. But it's important. If you don't ask, you're not going to find the answer. And so that's an example of a genetic mechanism and an environmental mechanism which converge on the same pathway. The next case, a 44-year-old female who has long-standing hypertension. She's been poorly controlled on 3 drugs. She switched to a new doctor who noticed that the patient has a potassium of 3.4 and again has a metabolic alkalosis, off diuretics. There's no family history of hypertension. This patient has elevated, has low plasma renin, 2.2, but elevated aldosterone again, okay? And you can sort of appreciate that by taking a ratio between your aldosterone to renin. Renin, as you remember, is your normal physiological regulator of aldosterone. The levels of these two circulating hormones have to be correlated. And the ratio normally is about 10 to 20 when you use these units. And so here you have a ratio of 72, which indicates, again, that there is something wrong here. You have dysregulated production of aldosterone. So you have to think when you have elevated aldosterone level and with suppressed renin level, you have to think there's something wrong with the adrenal gland again. So that's when you order an imaging study. And so I was supposed to do this lecture with Dr. Newhouse, and unfortunately he wasn't available today due to a family event. So I'm going to try to do my best to go over this. This is a CAT scan. You've gone through radiology. You know about how to read CAT scans. So this is as though the patient is lying down, and you've cut a slice through their abdomen this way, and you're looking down inside their abdomen. So these are your 2 kidneys, and this is the one adrenal gland that's supposed to sit on top of the kidney. To give you an idea about what a normal adrenal gland should look like in one of these images, it should look like something like this. And here, this is the adrenal gland in this individual who has Cushing syndrome. This is a syndrome where there is an excess of glucocorticoid that's being produced by the adrenal gland or by excess production of ACTH, which is, again, in your brain. This is a patient who has Conn syndrome, which is an aldosterone-producing tumor in the zona glomerulosa, okay? And so the two of these, you cannot distinguish, if it is Cushing syndrome or Conn syndrome simply by the imaging study. You're going to have to do the sort of measure the hormones to see, to predict what is being overproduced by these tumors. You can have also a situation where you're going to have what we call hyperplasia. So in other words, a growth of adrenal cells that are in excess to what we should encounter normally. And so this is, again, a situation where you have overproduction of aldosterone due to hyperplastic cells in the adrenal glomerulosa. And so this is a case of primary, what we call primary aldosteronism. So this was called, again, primary because we didn't understand the mechanisms for this. This name is going to have to change because now increasingly we're understanding what is causing primary aldosteronism. This is very common in patients who have moderate to severe hypertension. So it's reported in up to 10% of people who have uncontrolled hypertension on 3 drugs. And it's 40% of the cases are produced by aldosterone-producing adenomas. These are benign tumors. They're usually unilateral. And they're curable by surgical removal of the adrenal. So this is a reversible cause of hypertension, and you can save this patient a lot of complications and prolong their life if you pick this up and you surgically remove the adrenal gland. 60% of the cases are caused by adrenal hyperplasia. That tends to be bilateral. And so in these cases, if you notice this, then you can have essentially a personalized treatment for them because you're going to give them a mineralocorticoid antagonist, which is going to be effective in reducing blood pressure. So why do I say we're probably going to change the name of primary aldosteronism to something else, is that we realize now that many of these aldosterone-producing adenomas are attributable to somatic mutations. Essentially, these are not mutations that you inherit, but these are mutations that develop in our own cells in the adrenal gland. And so normally what we have is a hyperpolarized cell membrane in the adrenal glomerulosa cell. And what happens is that this prevents entry of calcium into the cell. When you have entry of calcium when you don't have entry of calcium in a hyperpolarized cell membrane, you don't produce aldosterone. It's only when you have activation of calcium, which this can happen only if you have elevated potassium level in your blood, essentially, or you have angiotensin II, which prevents the exit of potassium. That's when you activate your calcium channels. Entry of calcium depolarizes these membranes and results in aldosterone synthesis. Okay. These patients have developed a mutation in the potassium channel, which makes it leaky to sodium, essentially. So they have a chronically depolarized membrane, which results in entry of calcium and, again, dysregulated production of aldosterone. What we're finding is that this accounts for maybe about 20% of cases of aldosterone adenomas. There are additional mutations that are being found almost every year in the same pathway, so essentially changing, and most of them involve changing essentially the polarization of the membrane. And so we're going to be able to identify these patients a little bit better, understand the mechanisms a little bit better. But as you can imagine, all of these new channels that we're discovering and their actions can become site of action of new drugs for therapy and sort of modulation of your aldosterone production. So real progress that's been made just in the past few years in understanding the pathogenesis of the disease that for about 50 years we've been calling primary aldosteronism. So another case, an 18-year-old, no past medical history, who has a very high blood pressure during a routine physical exam, no family history. She reveals that on exams there's a high-pitched bruit in the upper abdomen, in the subcostal area. Okay, not subcostal. Sorry, that's a typo. Serum potassium 3.8, so it's normal. The renin-aldosterone and aldosterone-renin ratios are normal. What you do notice is that when you do a renal sonogram in this individual, one kidney is much larger than the other. Your normal kidney size is about 10 centimeter in your average individual. And so you want to do another imaging study. An 18-year-old should not have such high blood pressure. And so when it's an 18-year-old woman who has a bruit, what does bruit tell you? What does that tell you? That's the manifestation of turbulent blood flow. So there's something going on in the abdomen, and so we're looking, there's a discrepancy in kidney size, so maybe something's going on with the renal vasculature. And so what this patient really has is a classic presentation of fibromuscular, what we call fibromuscular dysplasia, which is essentially abnormalities in the blood vessels in many arteries, particularly the renal arteries, which results in stenosis or narrowing of the blood vessels. And he has this really typical string of bead appearance on an angiography and that you can see. And this is a CT angiogram, essentially, where you see the same thing. And so this is really this is a rare disorder. But if you see this, it's almost virtually only seen in women for a reason that we really don't understand. This happens to affect the renal vessels quite a bit, but it can also happen in other blood vessels in the brain, for example. You can be predisposed to stroke, and so on and so forth. So that's the most common cause of renal artery stenosis. The other way you can have renal artery stenosis is by atherosclerotic disease, and this is a disorder of older individuals. And when you do an angiogram, the difference is that there's a filling defect essentially in the arteries of the patients, and it looks like people have taken a bite out of the artery essentially. You can see this again on a CT angiography and reconstruction of the blood vessel. So another way you can evaluate this is by doing a renal sonogram or a Doppler. Doppler essentially is, you can't tell really anything. Blue and red just indicate flow. And by looking at the waveforms, a radiologist can tell if there's perturbation in blood flow and can detect potentially renal artery stenosis. So what's the pathogenesis of renal artery stenosis? If you have two kidneys, and usually these tend to be unilateral, there's reduced perfusion to the one kidney. There is local renin-angiotensin production because this kidney is sensing low blood flow. And so when you increase the renin-angiotensin system, this other kidney is also exposed to it. So you start to, it starts to increase this blood flow. It's shutting down its renin-angiotensin system locally, but it's still under the effect of the increased renin-angiotensin system from the other kidney. So you start to you have impaired sodium excretion. And so you have increased sympathetic activation, aldosterone production, sodium retention. And so you have vasoconstriction on the one part because of angiotensin 2, but you have extracellular fluid expansion, and that resulting in chronic hypertension. And so as long as stenosis is not corrected, you're not going to you're not going to cure the hypertension. The good news is that in many cases, if you catch this early enough and you do relieve the stenosis, you're going to cure the patient of hypertension. And there are three phases, and the key is to remember these and try to think about it in terms of when you can intervene. If you look at renin levels in blue or blood pressure, and this is a timeline, okay, looking at what happens. So if you have sort of normal levels, this is sort of arbitrary values here. If you produce a stenosis, let's say you do this in a dog, then you're going to have high renin, and then your blood pressure starts to increase. So if you give at that point a renin-angiotensin blockade, you remove the stenosis. This is phase 1 within weeks to months. Then you're going to completely normalize things, and things are going to go back to normal. If this lasts longer, so months to years, what's going to happen is that you're going to have to sustain high blood pressure, but over time, your renin level starts to autoregulate and starts to be suppressed. And this is what we see in the patient that we presented, where the patient had high blood pressure, but normal renin levels, okay? So even though the patient has renal artery persistent stenosis, they may have completely normal renin levels, which is the most common finding in patients who have renal artery stenosis. And so when you are in the clinic, you have to, just because the renin level is normal does not mean that the patient does not have renal artery stenosis. And so you have to order an imaging study to be able to evaluate and understand this. The good news, again, is over a period of months to years, it depends on different people and different people's physiology. Again, if you intervene and you remove the stenosis, the blood pressure comes back to normal. And so that's, again, a potentially curable form of hypertension. If this lasts a very long time, okay, and so now you start to have remodeling of your vasculature. And so as a result of this, then if you start to relieve the stenosis, you may not cure the hypertension, or you may improve the blood pressure somewhat, but it may not go back to completely normal. So this is going to be poorly reversible. So the key is to have a high index of suspicion and try to evaluate for this earlier on. So particularly a young female with severe hypertension, you got to think about this. In addition, older individuals who have risk factors for atherosclerosis, think James Bond, okay, then you're going to, or people who have a lot of different risk factors for it, then they're going to have, you should screen them for renal artery stenosis. So I just went through all of these. The treatment for this is for angioplasty. Essentially, you balloon. With a balloon, you open up the stenosis with fibromuscular dysplasia, and this is usually curative in that vessel. You just have to be aware that this individual may be prone to developing this in other vascular beds, so they will require continued monitoring. The atherosclerotic disease in older individuals, it's a little bit more complicated. You have to think about it in patients who have a long history of smoking. Many of these patients develop what we call flash pulmonary edema, and every month we get 1 or 2 of these folks admitted to the hospital. They're unable to cope with their salt load, and even though they have normal cardiac function, they develop pulmonary edema in the setting of normal systolic function. And so, I think there's still a lot of controversy about the best optimal treatment. It seems like angioplasty with a stent seems to work in a subset of individuals, but not for everybody. And I think we're still working on identifying the best treatment for this in atherosclerotic disease, which is really kind of complicated. So, just to go back, if you think about, what's the pathogenesis, again, of acquired genetic aldosteronism, each time, again, you're talking about salt reabsorption in the distal nephron, or activation, and in the case of renin-angiotensin system and renal artery stenosis, activation of angiotensin II, resulting in salt reabsorption in the distal nephron. With angiotensin II production, you also have vasoconstriction, which further contributes to the hypertension. Okay, so this is a patient, this is a drug rep I talked to one time at a meeting. She talked to me because she found that I'm a nephrologist. 54-year-old who had episodic hypertension, blood pressure as 120 as high as 240 over 120 with fluctuations down to 148 over 90. She had very non-specific symptoms: anxiety, dizziness, headache, palpitations, and a little bit of orthostasis on exam. Serum potassium was normal. Renin-aldosterone and aldosterone-renin ratios were also normal. And the serum and urine studies for catecholamine metabolites were elevated. So she actually diagnosed herself. But the doctor, based on her symptoms, said, well, you just have general hypertension, you're just anxious. And she started reading the web about this and thought, boy, I must have something else. I really need a serum and urine catecholamine measurement. And it turns out that she had this syndrome called pheochromocytoma, okay? And this is a tumor, essentially, that you can see, again, in the adrenal medulla, which is responsible for production of catecholamines. And you can see this here on a coronal section, again, the kidney and the adrenal gland. This can also be detected by a radioisotope scan called an NMIBG scan as well. And so, again, you have to have a high index of suspicion. These are neuroendocrine tumors that arise in the adrenal medulla. They produce an excess of catecholamines. They're usually really poorly diagnosed. The patient has to have hypertension. It could be very episodic. And the triad of headache, palpitation, and sweat have an 85% diagnostic sensitivity. That's what's been classically reported in the literature. But, let's think about it. When you're about to take an exam, how many of you experience headache, palpitation, and sweats? So it's fairly common in the population. And so, again, high index of suspicion to see what's going on in the patient, particularly if the hypertension pattern. So when I went to medical school, these are the rules that we had, that 10% of them are extraadrenal, 10% of them malignant, 10% of them are bilateral, 10% of them were genetic, and 10% of them have no hypertension. I think these are really rules of thumb. That's because we were lumping all these tumors together. They were poorly detected. Initially, we didn't have the good ways of detecting these radiologically. And so these numbers are quite variable. But you have to remember that you can have extraadrenal, malignant, bilateral, genetic, and normotensive pheochromocytomas. And these can occur not only in the adrenal glands, but it can happen also in other parts of your nervous system. So you can have paragangliomas somewhere in your neck, in the spine, and so forth. Now, increasingly, we're identifying genetic mutations that result in pheochromocytoma. These are usually germline mutations, inherited mutations. So it takes a while for these tumors to grow. There's an expanding list of these. But what's really important to realize for these is that they each come with their own subset of complications. So you will hear about multiple endocrine neoplasia. That's the classic endocrinopathy genetic form. And so this particular one with mutations in RET is associated with medullary thyroid carcinoma and other and pheochromocytoma, whereas the other one that's caused by succinate dehydrogenase mutations, this one presents with a complication of renal cell carcinoma. So you have to, and there's a very high incidence of extrarenal tumors as well in malignancy. So as we're starting to define the genetic causes of these disorders, we can start to parse the patient's space and better assess their risk factor for additional complications as we go forward. And so this is, again, an expanding list. This is current as of 2012. There's going to be more genes that are going to be added to this list by the time I present this lecture next time. So again, a high index of suspicion is needed, but here you have really a high adrenergic input as the cause of it. So why do I put this slide on? People have seen this movie. Do you remember this scene? So what's in front of him? Cocaine, right? So this is the exogenous equivalent. This is the environmental equivalent to this. Your patients who abuse cocaine are going to be hypertensive, and so you're going to see this in the ER. The patients who come in, you're going to be hypertensive. You're going to do a drug screen. They're on amphetamines. They're on cocaine, and so it acts in the exact same pathway, except here this is an exogenous form of catecholamines that are being administered to the system. Okay. Here's another 24-year-old woman who's 6 months pregnant and has persistent hypokalemia during pregnancy. The outpatient management with potassium supplementation has not corrected the potassium, and the blood pressure in this patient is getting lower and lower. And so the internist doesn't know what to do with it, and really suspect that the patient is trying to is abusing diuretics and may harm the fetus. They consult a psychiatrist who decide to commit the patient to a locked ward. Okay, this is a real story, by the way. So the blood pressure is low. Normal cardiac exam, no edema. Renin, angiotensin, renin and aldosterone levels are very high. And after 1 week in a locked ward, she says she has consistent hypokalemia. So in other words, here you control everything that she takes in, and she still has the hypokalemia. So they say, okay, well, we're going to call a nephrologist. So they're going to call a nephrologist, and once you start looking at this, and this constellation of symptom actually is quite telling for a nephrologist at least, because this is a diagnostic of two really disorders that are genetic disorders. One is called Gitelman syndrome, the other one is called Bartter syndrome. And they're caused by loss of function mutations in sodium chloride transporters in the kidney. Gitelman syndrome is caused by mutations in the thiazide-sensitive sodium chloride co-transporter that's responsible for reabsorption of 5 to 7% of your salt load in distal convoluted tubule. This is what this patient has. This is a milder form of hypotension with hypokalemia, okay? And this is due to essentially this is equivalent to being on a thiazide diuretic regimen. And so that's why the internist had thought that the patient is abusing diuretics. In fact, unless you do the genetic test or you do a diuretic screen, the two syndromes are completely indistinguishable. So that's one form of disease. The other form is caused by mutations in one of 3 genes that are responsible for handling salt reabsorption in your thick ascending limb. Your sodium potassium to chloride co-transporter, which is the site of action of loop diuretics. The ROMK channel, which is responsible for the back leak of potassium, which is necessary to keep this reabsorption of potassium going here. And the chloride channel that's responsible for exit into the blood side. And so again, this is called Bartter syndrome. It's more severe and presents usually in the pediatric age group, because this pathway is responsible for up to 30% of the salt reabsorption. So these patients have often neonatal or really pediatric hypotension, and they get hypokalemia because at the distal side, once you start having a lot of salt loss, what happens? You activate the renin-angiotensin system, you activate the epithelial sodium channel in the distal nephron, so you start to avidly reabsorb salt in the distal nephron, but it's probably not enough to keep up with the massive salt loss that's happening proximally. So even though this side of the nephron is working maximally, it's unable to compensate, and so the patient still has hypotension. And They have hypokalemia because as you reabsorb sodium, you secrete potassium. And they have metabolic alkalosis because they're volume depleted, and in addition, they're secreting hydrogen as well as they're reabsorbing salt. We're going to go over the acid-base balance and the potassium in later, but this is really important for you to remember this. And these are, uncommon, but something to keep in mind. And of course, they really resemble, environmental or diuretic, overdose. And so you should keep those in mind, and in terms of their metabolic profile. So we talked about the pathogenesis, what happens, and why you have the hypokalemic metabolic alkalosis in the patients. So to date, all genes implicated in human hypertension act by augmentation of net salt reabsorption. That's pretty much the pathway. And so acquired and pharmacological interventions in the same pathways are effective in controlling blood pressure. And so that really suggests that interventions that reduce salt intake in the general population is really going to reduce the incidence of hypertension. And in fact, there's a concerted effort to do this in different countries and around the world, particularly in England. And as you solve these genetic forms of hypertension, now you identify new targets that you can, where you can develop drugs to develop new antihypertensive medication. And so now I'm going to skip this slide, but I can just tell you again that at the end, this is a summary slide which describes the different systems that are affected, the syndromes that result in low blood pressure or high blood pressure, and then the pharmacological therapy that targets these particular systems. And you can review all of these. That's it. Thank you. The hypertrophy of the young kidney with the renal artery. So this is basically when you have increased blood flow. There's compensatory hypertrophy.
Increased blood flow is a way to compensate for the string of beans on the right side.
And there's increased blood flow on one side and then there's reduced side. So the other one has reduced in size, so there's reduced blood flow to the other side, and the other one has the increased blood flow. Very often, yes, very often. So that usually tells you, the two combination tells you that you have aldosterone. Because with aldosterone action, essentially, you reabsorb salt, you excrete potassium and hydrogen. Yes. Well, you get rid of extra hydrogen, so that's like generating bad hydrogen. So they're vasodilators. At least the ones that are targeted. So they're important in the regulation of the
So you mentioned something around salt and I was just curious what that was. It's like public health
It's a
effort?
public health effort. They're trying to reduce salt in generally for the population. I mean, the public health effort is they talk to the food industry. So they've made a concerted effort to reduce the amount of salt they prepare food. So
And
that's
how long
actually
has that been going on?
for a number of years. In fact, the initial the interim studies suggest that there was a reduction in overall blood pressure. The food industry really is fighting this because by adding salt to food, you cook too, and you preserve it, and you mask other things that you put in
I'm really interested in like the preventative public health aspect of hypertension. I'm wondering if like taxing salt could
Bloomberg was
reduce.
thinking about this, right? This time to do salt tax on the roads, soft drinks. This is a huge salt bill. And so this issue has been clear to I think the patient
Well, you know, it's interesting. We had a lecture on COPD, and the lecturer, she's a pulmonologist, and she said it had like a list of the top 10 causes of morbidity and mortality in the world, and number one was hypertension. Number three was COPD, and she said you look at this list, and COPD is the only one of these conditions that's preventable. And I was like, how is, I raised my hand and said, is it hypertension? And she said no.
to some extent it is. I think it is if you reduce enzyme
It seems like if you just don't eat processed foods and you prepare your own foods, you could eat a pretty basic.
so you should talk to Andrew Moran.
Andrew Moran.
This is the guy who's the first author that we looked at the paper and that there's a difference in the public health stuff. There's another group that's doing behavioral
All right, I'll look him up. Thank you.
Okay.
Good morning. So today's talk is on the treatment of hypertension. So you know this is a problem that all of you will experience, both as doctors and patients. So guaranteed, 2/3 of this room are going to get hypertensive by the time you're 60. So heed my words carefully. All right, most of the material that I'm going to talk to you about is from what we call guidelines. Guidelines are essentially the opinion based on evidence that a group of experts gather every so often and say, look, this is what we recommend for the diagnosis or treatment of a given disease. And it is the same with hypertension, and these references are important if you need to go back and check on some points that I've raised that you're not clear about, okay? So what we'll do is we'll define hypertension, we'll talk about the principles of treatment, and then apply these principles to specific groups of patients that we see in our clinics on a fairly regular basis. I have no conflict of interest. I'm clean. All right, so so hypertension is a number, but not really, because we've got to start somewhere. And the number we use is, for a normal person, a blood pressure less than 120 and that's systolic, and a diastolic that's less than 80. And we'll tell you why these numbers, where do they come from. And then depending on how high the blood pressure is, we go into certain stages. Pre-hypertension is given its own category because we know that if you're in this yellow box, your risk of bad things happening is a little higher than if you're not in the yellow box, you're in the white box on the top. But we do not know if treatment of this box is going to lead to any improvement in this outcome. Okay? But we know for sure if you're above 140 and especially above 160, if you do not treat, you are going to suffer. To give you an idea of how many hypertensives there are, so 1/3 of the population of the entire US are above 140/90, right? Of which only a little less than half are controlled. And if you look at the folks who are not controlled, 40% are not aware. So they've never seen a doctor or never stuck their arms in a drugstore blood pressure machine. And about 15% are aware, but they're not treated. Now, I wonder why that is now. Could be that they just refuse because there's a little cognitive dissonance. I have a high blood pressure, but I'm feeling 100%. Why should I take a medication, right? But the more sort of disturbing point is that, we know of these 44% of these uncontrolled patients who are on treatment but are not controlled, and there's a whole host of reasons why they should be, and we'll talk about some of them that we can try to fix, okay? But it's a huge problem, just in numbers, and it's a huge problem because, most, or actually half of these patients are not hitting targets, despite there's very good evidence showing that controlling blood pressure is a huge gain in terms of life and productivity to the society. So this was your, the prelude was that, 115/75 is your ideal blood pressure. And every time you double, every time you increase your blood pressure by 20/10, your risk of cardiovascular disease goes up by double, twice the amount. Okay, so that's your approximate gain you'll get by lowering the blood pressure. So the first thing we do when a patient walks into our clinic is not just look at the blood pressure, but look at what else could be causing the cardiovascular system to suffer in the future. And these are some of the known risk factors that I'm sure all of you are aware of. Okay, but smoking, body mass index, lipids, diabetes, they're all fixable. And of course, age doesn't wait for anybody. We can't fix that. And there's a family history. You cannot change your parents, so you cannot fix that. But the top four are eminently fixable, and we have to put this in a package of how we manage patients with high blood pressure. So what high blood pressure is associated with is essentially cardiovascular disease and kidney disease, right? So your risk of coronary artery disease goes up. Your risk of thickening of the heart goes up. Heart failure is very, very common in uncontrolled hypertension. Your risk of strokes go up. Kidney disease, if you've got any cause for kidney failure, it's going to be magnified if your blood pressure is not controlled. Now, there's a controversy you saw yesterday whether there's an entity called hypertensive nephrosclerosis. In most of us that we've been practicing, we think there is such a thing, but it's clear that if you have any kidney disease, it is going to get worse if your pressure is not controlled. And of course, peripheral artery disease and retinopathy all form the package of what we call target organ damage, which accrues from uncontrolled or high blood pressure. And you don't have to go through this, but it just tells you that as your pressure goes from high normal to grade 3, and if you have risk factors that are present in increasing amounts, your risk goes from okay to low to very high. And I just want to point one thing, is if you have symptomatic cardiovascular disease, if you have kidney disease greater than stage 4, or if you have any diabetes, okay, your risk irrespective of your high blood pressure level, is extremely high. So these patients have to be specially targeted towards trying to modify these risk factors. And as you get on the other stages, the higher the pressure and the more risk factors, you can see that you really have to put a lot of effort into managing these in patients with high blood pressure. And here's the bang for the buck slide. Okay, so if you control blood pressure, your heart failure rate drops by half, your stroke rate drops by 30%, your thickening of the heart muscle drops by 30%, death rate drops by 20%, and events like heart attacks and strokes drops by 18%. So this is what you'd expect to do when you treat your patients with high blood pressure who were previously uncontrolled. And it's a big number. It's critical to know how we measure blood pressure. This might change because we are now depending almost completely on the office blood pressure to monitor and treat your patients. I'll submit to you that that's a very, it's like a serum creatinine. It's fraught with problems. It's not an ideal number. So there's a movement now that's underway that's going to use the so-called ambulatory blood pressure monitoring as an important adjunct to office blood pressure in how you manage your patients. And the reasons for this is your pressure may be very high in the clinic and could be completely normal at home. So if you wear a 24-hour monitor, which measures your pressure every 20, 30 minutes and every hour when you sleep, you can get a broad overview of what's going on in the patient's life, okay? And then decide whether or not you're going to treat or not, okay? And then there's this thing called self-measurement, home blood pressure. It's the same technology as we use for ambulatory blood pressure monitors. And you can do this twice a day at home, and you get much better readings than what you would do in a clinic reading every 3 weeks or 4 weeks, okay? So all these techniques of measurement, each of them have their value and problems, okay? So like with everything else in life, nothing is perfect, but we use all three together to help treat our patients. So when we come to hypertensive therapy, it's not just drugs. There are a whole other set of issues that you need to address. Lifestyle changes, comorbid diseases, side effects of drugs. Can the patient afford the medication? So all these need to be considered before you write your prescription. So when we consider treating the patient, so it's not just, the most important part is just making the diagnosis right. So one reading doesn't make you hypertensive. So we need to get all these aggregate readings, home readings, perhaps an ambulatory blood pressure reading before we say, yes, this patient is truly hypertensive and needs to embark on a lifelong treatment regimen. We will discuss secondary causes. When would we work up a patient? Workup is expensive. It could be invasive sometimes. So 99% of patients with high blood pressure do not have what's called a secondary cause. Their pressure is up for reasons that we cannot find or treat. Okay, so that's what we call essential hypertension. Then we talked about estimating the cardiovascular risk, other risk factors. Need to carefully consider the presence of comorbid conditions because it will affect the way you treat these patients. There are certain lifestyle changes I'll go into which are very important and cannot be separated from the overall management of this patient. And then finally we talk about drugs. So that's the amount of thought or the amount of sort of workup and other considerations that have to be looked at before you write your first prescription for this patient. So when should we consider an expensive and perhaps invasive workup of causes that might be fixable? So one situation that jumps to mind is you've tried a whole bunch of drugs and the patient is not being controlled. That's one situation. The second is someone's cruising along, has had a history and physical every year with blood pressures of 120 and now suddenly comes to your office with 200 systolic. Okay, this sudden uptick in the blood pressure readings over a very short period of time. Someone who's previously well controlled has now become uncontrolled. Any severe hypertension, that's a maybe, and it all depends upon situations, but it's not as prominent as the first three. And then there are certain clues in the history, physical exam, and the lab test that might suggest that there's something underlying this hypertension, and we'll go over that in a few minutes. So these are the 5 broad categories of conditions that are associated with hypertension that you could potentially treat. So the most common, and that's because we are all here, is the kidneys, right? So I'll submit to you that blood pressure comes from the kidneys. And why is that? Because the majority of patients who've got high blood pressure have one of 2 problems. The first is salt retention, right? And it's been found that salt is intimately associated with high blood pressure. And the second is that the kidneys, you may not know this, but is an amplifier of the sympathetic nervous system. So if you get something that's happening elsewhere that's causing the sympathetic system to go into overdrive, it's going to feed into the kidneys through nerves, and then the kidney actually feeds back into the hypothalamus through the same set of nerves. So there's this reverberating circuit that's existent. And in fact, there's been trials looking at renal denervation to treat high blood pressure that's difficult to control. So you put in a balloon with an electrode which fries the renal nerves but keeps the renal artery intact. It's new technology. Trials are still ongoing. There was one trial that was negative, but it's not over yet. So the kidneys can be unhealthy, and that actually causes salt retention. It causes the sympathetic system to go in overdrive. So how do you know there's a kidney problem? We've heard this ad nauseum, I think, so far. Look at the urine, look at the creatinine, and look at the ultrasound. You need these 3 items to make sure there's no kidney problem. If you have a blockage of the kidney arteries, you get you get a low blood pressure in that one kidney, distal to the blockage, or also called stenosis, and you rev up your renin and aldosterone levels, which then, as you know, leads to angiotensin II elevation and aldosterone elevation. So both these are pro-high blood pressure stimuli. And we can look at this by certain testing. You can either do a Doppler or something called a capillary scan. We'll talk about ACE inhibitors, right? If you are pre-renal and you give an ACE inhibitor, what's going to happen to flow? It's going to drop, right? So you use this differential effect to look for a blockage of the kidney on that side, because the side that's stenosed, you give an ACE inhibitor, will have a very, very sharp drop in GFR that you can look and see on a camera, which is emitting gamma waves from a radionuclide tracer, right? So that's a great screening test for one-sided blockage of the kidney artery. You may have coarctation, which basically means you're cutting off blood supply to the lower extremities and the kidney, but your pressure in the proximal part of the blockage of the aorta is very high. And that can lead to hypertension in the upper limbs and low blood pressure in the lower limbs. So you always should check blood pressures in 3 limbs to make sure this doesn't exist. And then finally, we can have patients who are secreting aldosterone inappropriately. And this leads to a low potassium in the serum. So a low serum potassium is a marker that aldosterone levels might be high. And it's a great way to screen for this condition, because if you do a blood sample for aldosterone and renin, someone with a high aldosterone level is going to have salt retention, will suppress the renin, but the aldosterone levels are high because it's being secreted without any control. So this aldosterone to renin ratio is a very important screening test to look for this condition. If it's over 20, it suggests that you have an autonomous secretion of adrenals, and then you look further with imaging to see if it's coming from one adrenal gland or are both adrenal glands hypoplastic. And then finally, you may have a catecholamine secreting tumor called a pheochromocytoma. And this is, again, autonomously secreting norepinephrine and epinephrine into the bloodstream. And those are vasoconstrictors. It elevates your heart pumping. Cardiac output goes up. So these people get episodes of anxiety, palpitations. Heart rates are higher than normal. And you get these spikes that correlate to the release of these catecholamines. So these are all signs that there may be underlying pheochromocytoma, and then we can simply measure plasma catecholamines or its byproduct called metanephrine. And you can do that in the urine as well. Because these are all screening tests for these 5 conditions that lead to or can worsen high blood pressure and are treatable if you catch them early, especially. So what we do in an uncomplicated patient is we look at target organ damage, and we look at perhaps secondary causes, okay, which we look. So every patient should get an electrocardiogram to look for heart muscle thickening, also known as left ventricular hypertrophy. Some experts would advocate a limited echocardiogram because it's much more sensitive than an electrocardiogram, but it's more expensive. So we don't routinely offer this. Every patient should get a urinalysis. They should get a blood glucose to look for diabetes or hemoglobin A1C. You may get rarely high blood pressure with polycythemia, so we look at the hematocrit. And then the basic metabolic profile is important because low potassium and elevated creatinine could suggest the issues that were mentioned. All patients should get a lipid profile to look for hyperlipidemia, and then kidney damage, also look at microalbumin. So these are the basic tests we would order in someone who's being looked at with a new diagnosis of hypertension. And most of these patients will get them serially every year, every 2 years to see if these problems have developed since the onset. So let's look at the goals of therapy. And remember, this is not written in stone. The data are pretty good in hypertension, but it's not perfect. So there's a lot of opinion in these guidelines. You got to know this. But you got to start somewhere, isn't it? So if you take an adult who's over the age of 18, who's been diagnosed with hypertension, every patient should get lifestyle intervention. We'll discuss what those are. And should continue these lifestyle by reinforcement throughout their lifespan. So we need to set a blood pressure goal, and we'll talk about the goals in the bottom part of this slide. And then based on certain demographics and certain comorbid conditions, we will implement blood pressure lowering medications, right? So let's take on the left a patient who doesn't have diabetes or chronic kidney disease. Remember, those two are the highest, or the most powerful risk factors, which amplifies the effect of blood pressure on cardiovascular risk. So if you get a patient over the age of 60 who's otherwise okay, your goal blood pressure is 150/90, okay? If you're a younger patient, less than the age of 60, your goal blood pressure is below 140/90, okay? When you move to the right, if you have kidney disease or diabetes, whether or not you're older or younger, your goal blood pressure is below 140/90. So just remember these two goal blood pressures. Older, 150/90, younger with these two conditions, lower than 140/90. So these are your lifestyle modifications, and if you do them right, this is what you might expect. Okay, so if you reduce weight, every 10 kilos, you may drop your systolic blood pressure somewhere between 5 and 20. So obesity is a big one. Okay, you all heard of the DASH plan. It's a dietary approach to stopping hypertension. It's a well-designed, NIH-funded, not McDonald-funded diet study. So you're looking at a Mediterranean diet, lots of fruits and veggies, limited amounts of marbled steaks, okay, more fish and chicken, and salt restriction. So salt less than 5 grams a day. So if you put these into a diet plan, it's been shown that you can reduce your pressure between 8 to 14 millimeters of mercury. Okay. Salt is important, but the amount of blood pressure reduction with salt varies. So the higher the blood pressure, the more the bang for the buck you get with salt reduction. So if you're just at the cusp of being diagnosed as being hypertensive, you may not get a huge drop in blood pressure, but if you're really high, and in conjunction with medications, you will get a big drop in blood pressure. And physical activity and moderate consumption of alcohol all are helpful. So moderating the consumption of alcohol, we're not advocating that you go and drink, okay? Although that's debatable. Okay. So let's look at why these drugs work, okay? Where do they work? So if you look at the blood circuit right here, you got a pump and you have a resistance, right? And you have an outlet, which is the kidneys. Your blood pressure is a function of these 3 variables. So if you reduce the pump power, or if you reduce its resistance, or if you increase the volume of, or you decrease the volume of the plasma by, say, giving a diuretic, all these may lower blood pressure, okay? So if you look at that picture and then you look at the drugs available, so broadly there are 5 classes of drugs. Okay, the first will lower the amount of sodium in the system. Okay, and then the most important drugs are thiazides, and thiazides are weak diuretics, which are good, but it turns out that reducing your salt balance by just a few percentage points does affect your peripheral vascular resistance, and the exact link is not known. Why would such a little bit of drop in your total body sodium content lead to such a big drop in your blood pressure? That link has not been established, but it does work. So 12.5 milligrams of thiazide will maybe make you pee for a day or two, a little extra, and then you're back into steady state. But your total body sodium is a little less, okay? But that's enough to control your blood pressure quite dramatically. We do not use loop diuretics in people with normal kidney function because they are too strong. We use them all the time when your kidneys are not working because your thiazides are just not effective enough. There's a huge role for aldosterone blockers because if you profile your patient and you find that there's elevated aldosterone levels, but you cannot find an underlying, say, adrenal adenoma, we would need to treat them medically, and those groups of patients really respond well to this class of agents. Question there.
Why are these number 1? Because they directly see in your immune system.
Which one?
Aldosterone antagonists.
There could be. It's a very good point, right? So there's a movement that afoot saying that these drugs are quite useful as even primary drugs. The reason why we don't put them as number 1 is we don't have that evidence based on large clinical trials. These are very old drugs, but their use in hypertension is just being analyzed. So that's, but you're absolutely right. You could very well use this. In fact, people have used this in combination with thiazides to match the side effect profile. Because you use a diuretic, a thiazide diuretic, you're going to lose sodium and actually lose potassium with it, okay? Because your aldosterone levels go higher, right? So putting an aldosterone blocker nicely offsets the side effect profile and actually augments the effect of a thiazide diuretic. It's a very good question. And hold on to the thought, because I'm going to come back to it. Then you look at adrenergic blockers, the pump, right? So you want to reduce the pump and perhaps dilate the peripheral vessels. So there are alpha blockers, beta blockers. Alpha blockers are peripheral agents. Beta blockers reduce the contractility and rate of your heart. So your pump function's dropped. It's not very effective because we think most patients with hypertension do not have an increased cardiac output. They're normal. So we focus more then on the peripheral vasodilators, right? Like, for example, an alpha blocker. But the alpha blocker is not used as first line because in one large controlled trial, the outcome was actually inferior to the other classes of agents that we spoke about. For the same reason, we don't use the direct vasodilator, because what happens with that class of drugs is that because of vasodilatation, you get reflex tachycardia, you get reflex salt and water retention. So you can add it on at the very end of all the other group of drugs, but never as a primary drug for this reason. Calcium channel blockers are remarkably safe and remarkably effective, okay? So they also have a slight diuretic effect intrinsic to their function, other than causing vasodilatation with the dihydropyridines like amlodipine and nifedipine, and the non-dihydropyridines like verapamil and diltiazem, they also have cardiac functions, inhibiting the cardiac output in addition to peripheral vasodilatation. And then lastly, we've got the RAS system blockers, and we have 3 classes here: ACE inhibitors, ARBs, also called angiotensin receptor blockers, and then finally we have something that actually knocks off the renin enzyme activity, direct renin inhibitors. And these are all very safe and effective drugs in the treatment of hypertension. So how do we put it all together? First of all, we use these drugs because I showed you the bang for the buck slide. When we give these drugs and we lower blood pressure, these events get improved quite dramatically. Death, MACE, or major adverse cardiovascular events, and kidney events, okay? All these are affected dramatically by using these drugs. Now, this slide is based on data that's available. So, you know, your aldosterone blocker doesn't come up just because the data is not there. But I do believe that these drugs work as well. But if you take a hypertension general population again, we divide this into 2 categories. ethnically because the response to these medications are different. So you take a non-black patient, which is otherwise healthy, doesn't have diabetes or chronic kidney disease, you can choose any of these drug classes. So you can use a thiazide at a low dose. We never use a high dose because you don't want the metabolic side effects. They're actually going to worsen cardiovascular mortality because your potassium drops or your sugar levels go up, which are the two major side effects of these drugs. It is going to reduce some of the good things that these things do. Okay? Calcium channel blockers, you can choose any one. Okay? You can use either an ACE or an ARB. So all these are based on very well-designed trials in a general population. Or you can use a combination. So if the patient has a blood pressure of 180 or whatever, this patient is not going to respond to just one medication. So we typically would use a combination from the word go. Okay? If it's a patient of African heritage, a black patient, calcium channel blockers and thiazides are much more effective than, say, an ACE inhibitor in this group of patients. Okay? Just in terms of observational study data that shows that these two classes of drugs are much more effective. But then again, if they don't respond to one or the other, you can always add on the ACE inhibitor. But this is just for initial therapy. It doesn't mean that these drugs are forbidden for future treatment. Okay? If you have diabetes or chronic kidney disease, the first drug to pull out of your armamentarium is an ACE or an ARB because that's been shown. Not only does it control blood pressure, but it reduces the risk of bad things happening in this patient. Okay? Mortality, being the number one patient, is dramatically reduced with this class compared to other classes. So this is your initial therapy plan, so just keep that in mind. I'm not going to go into the whole slide, but for each of these diseases that's listed on the left, there are certain classes that are better than others because in trials that they've shown to improve outcomes specifically for these group of patients. I'm just going to give you two examples. If you have heart failure, the current standard of care is that these patients should, in addition to being on a diuretic for symptom control, should be on a beta blocker, an ACE or an ARB, and perhaps an aldosterone blocker in addition. So if we give these patients all these drugs in combination, your risk of dying goes down quite a bit. Okay? So this is the idea behind this slide, is that there are controlled trials that prefer one drug over the other. Okay? So the question is, how do you choose a drug based on a patient's phenotype? And this is what we're getting into now, and Ali Gharavi is part of this, is personalized medicine, right, or precision medicine. That we're all different, right? So, and we have so many classes of drugs that affect different aspects of your body that controls blood pressure. So one person on patient 1, for example, has a lot of green, which has high-ish levels of renin and angiotensin. So if you do actually a population study, but take all your renin and angiotensin levels and plot them against urine sodium levels, there's a very different curve amongst all of you. So there are people who are highish for the same amount of sodium intake, and there are folks that are very low for the same amount of sodium intake. So a person on the high side would benefit with which drug would you think? Probably a ACE inhibitor or an ARB, right? Whereas a person on the low side could probably benefit from a diuretic. So this is how you can phenotype your patient based on very simple biomarkers. Patient number 2 is a little anxious, has a heart rate of 90, sweats a lot, could benefit with something that's against the adrenergic system. We didn't show that in the first slide because there are very, very few people of this phenotype, and therefore all the drugs that have been shown that are active against the adrenergic system doesn't do anything good to their outcome. But the patient's blood pressure will be much better controlled if you find these little hints of a revved up adrenergic system, right? And the last patient, which is probably the most common, as you get older, as your kidneys start not working, your sodium sensitivity goes higher and higher. Okay, so that's the reason why we say that if you're not controlling your blood pressure in your patient, at some point, either step 2 or step 3, you need to add a diuretic. And the biggest reason for not controlling your blood pressure is the lack of a diuretic. a complicated slide, but the important thing is that there are some combinations that make physiological sense and some that do not. Let's take the two classic examples, okay? If you take a thiazide diuretic, right, which is the best drug that you want to use along with this? It's an ACE inhibitor or an ARB. Why? You give a diuretic, you're going to rev up your renin-angiotensin system because it's slightly volume depleted. And that may offset some of the good things that the diuretic is doing. So you add an ACE or an ARB, it'll prevent that from happening. And then now you've got a much better controlled blood pressure when these two drugs are used in combination. You can use a calcium antagonist with an ACE for one reason, not from a physiological reason, but there's very good clinical trial data showing that this combination has the best bang for the buck in reducing cardiovascular mortality, reasons unknown. But this is a combination that we all favor for that reason. But physiologically, and diuretic with some blocker of the RAS system is ideal. This is a chart that you can go through at your leisure, but there are certain contraindications and for not using a drug. Okay, so I'll give you two examples which are very important. You cannot use a blocker of the renin-angiotensin system in pregnancy, because you will get placental insufficiency. Placenta requires the system to work during pregnancy, so it is contraindicated. You'll get fetal deaths, you'll get placental infarction. You cannot use a beta blocker in a patient with asthma because you need your beta 2 to keep your bronchial tree dilated. So using a beta blocker might precipitate asthma, especially if someone's not very well controlled. And yeah, if you have someone with heart block or a slow heart rate, you don't want drugs that are working on the electrical system of the heart, because they may precipitate a heart block. For example, verapamil in someone with a resting heart rate of 50 and perhaps a grade 2 block. You don't want to use a drug that's going to further lower their heart rate and their electrical conduction. So those are, you got to sort of know these things before you write your prescription. So you've got all these drugs now. Let's look at certain indications, and I'll throw some cases at you. Just keep these cases in your mind, because it highlights how we use this enormous amount of technology and medications to help patients by profiling them. What's going to help them? What's going to harm them? So this patient has hypertension with obstructive lung disease and a recent or evolving myocardial infarction. This is a 55-year-old patient with COPD and hypertension, has been controlled with nifedipine. It's a dihydropyridine calcium channel blocker, so it's a peripheral calcium blocker. Comes with severe chest pain for a day. Blood pressure is 170/100, clearly not controlled, and there's a soft third sound which indicates myocardial dysfunction. There's an ECG that shows an anterior wall MI. So she is not deemed a candidate for thrombolytic therapy because it's too late, and gets an echo at the same time, and it shows that her ejection fraction, which is typically about 60-65%, is now down to 35. So clear myocardial dysfunction, uncontrolled blood pressure, and she has a comorbid condition called COPD. How will you manage her? So you got all the drugs that you have, right? How would you use these drugs to help her and not harm her? So we would like to use a beta blocker, right? Because it's been shown very clearly in the peri-infarct situation to lower the risk of arrhythmias, sudden death. And it also quietens the heart because your oxygen demands goes down when your coronary arteries are compromised, right? Can we use this? Think about it. How about ACE inhibitors? It's a great drug to reduce afterload and also prevent remodeling, right? So from a cardiac standpoint, it's a very, very important drug. Can we use this drug? So if you go back to the history, this patient has obstructive lung disease, right? You could perhaps use a beta blocker, but you've got to be really careful. You do not wish to exacerbate bronchoconstriction, because that's going to put a lot of load on the heart. So perhaps not the best drug to use initially. But an ACE inhibitor is very, very safe. And there's no contraindication to an ACE. What is the main contraindication to an ACE inhibitor? Anybody know? Yeah. Yeah, so it can go both ways. So someone's in cardiogenic shock. She's not in cardiogenic shock, right? Blood pressure is high. and she's got severe kidney disease, especially with hyperkalemia, it becomes very tricky to use an ACE inhibitor because it's going to get your potassium levels very high. So your potassium is 5.1, 5.2. We cannot pull an ACE inhibitor in this patient. Okay? Having a kidney disease is not a contraindication. In fact, it's a good thing. We like to use this drug in patients who have kidney disease for the reason mentioned, because it'll actually slow progression. But you need to be careful of two things, that if the patient's slightly volume depleted and pre-renal, right? Patient may be in incipient cardiogenic shock. You may precipitate acute kidney failure because your squeeze on the efferent arteriole is critical to maintaining GFR in such a patient. So what we typically do is use a short-acting ACE inhibitor called Capricol. It's given as a 3 times a day drug, and slowly work your way up, okay, to a long-acting drug once you reach a good dose. That's a good point, though. But so you may precipitate acute kidney failure if you're pre-renal, and if your K is high, potassium is high, it may make it worse. Situation number 2. This is a 30-year-old woman with type 1 diabetes, has come to you with difficult to control high blood pressure on 2 drugs. Diltiazem, which is a mix of cardiac and peripheral calcium channel blocker. It's a non-dihydropyridine. And clonidine, which is a central alpha agent. So it reduces the sympathetic outflow from the central nervous system. Okay? Blood pressure is completely uncontrolled. You need to get this patient below 140/90. You're way up there. There's 3+ edema. Creatine's 2.2. It's abnormal. The serum potassium is high, 5.1, and a 24-hour urine protein is very high at 5,000 milligrams. Normal is less than 200 milligrams. So look at this case. If you look at guidelines, now this, from a kidney now we mentioned 140/90 for most patients with kidney disease, but perhaps it's a little lower, and the debate is still on, that we should maybe going a little lower if it's this much amount of proteinuria, especially in a diabetic patient. So it's a moving target, like I said. Most of us nephrologists would say, let's go a little lower than 140/90. Not based on clinical trial data, but based on observational studies. But the drug to use here is an ACE or an ARB. And if you have volume overload, you need to be on a diuretic. Okay, this patient is clearly got 3+ edema, lots of volume, is not on a diuretic coming in. So remember, my first rule was that if you are on 1 or 2 drugs and you're not controlled, you need to be on a diuretic. Okay, that's very important. So the point here is that if you use a diuretic in someone of this in this clinical condition, a thiazide is a weak diuretic, so you may not respond to a thiazide or a thiazide-like diuretic. So a loop diuretic would be indicated in this patient, sometimes in combination with a thiazide, depending on how much salt the patient's taken in. So can we use the ACE inhibitor in this patient? Remember, the one contraindication to an ACE was high potassium, right? So I would not use an ACE in this situation, but I would start this patient on high doses of a loop diuretic, maybe 80 to 160 milligrams of a loop diuretic. Bring the volume down, okay? And what's the good thing that's going to happen when you give a diuretic? The potassium is going to start drop. And now you can use an ACE inhibitor, a drug that's going to save this patient's kidneys for a little longer than if you were not to use an ACE inhibitor. So you're using an important drug to slow kidney progression, and we are allowed to use it by a side effect of a drug, lowering the serum potassium. Okay? So we are using a side effect of a diuretic to control her potassium, and then you can put on an ACE inhibitor. So it's a nice little trick that we have up our sleeve to be able to use both drugs effectively. Yeah.
Is the high blood pressure possibly also a sign that the clonidine is not working anymore?
No, you're right. So the reason why the blood pressure is not controlled is just one, is that you're not taking the salt away, right? That's the number one reason, okay? If you have any edema, it means the moment you get a trace of edema, you know how much your total body water goes up by, salt and water, goes up by about 5 pounds, just by getting a little trace of edema. So you need to drop their weight by about 5 pounds before we can expect these drugs to begin to work. So if you've got 3+ edema, it's about 20 pounds of salt and water in both. And no, you throw 6 drugs, it's not going to work, guaranteed. Right, let's look at the third situation. This is a little more trickier. Why? Because this is an emergency. This is a 40-year-old man who's brought to the emergency with 3 days of progressive shortness of breath and blurred vision, both eyes. Here the blood pressure is sky high, 230 over 140. Patient's lethargic. There's an eye exam. This is what it looks like. This is the optic cup. You can barely see it. And there's all these white patches. And you can see a big blowout right here with hemorrhages, right? Another hemorrhage at the level of the macula. Classic of what we call hypertensive retinopathy. You essentially have a complete failure of your endothelial cells. So everything's leaking out into the surrounding tissue, causing edema, necrosis, hemorrhage. The same thing's happening in the brain, right? Because it's one organ, eyes in the brain. Therefore, the patient has hypertensive encephalopathy. The chest has bibasilar crackles. There's a S4 gallop. There's upgoing plantars in the neurological exam showing severe cortical dysfunction. There's some edema. Potassium is low. BUN and creatinine are slightly elevated, actually quite elevated. And here's the X-ray. You can see pulmonary edema, right? Urine shows some cells and some protein. So this patient is in the throes of what we call malignant hypertension. Malignant hypertension is a unique subset of patients with hypertension. It's not simply an elevation of very high levels of blood pressure. It's the end organ damage that's happening over minutes to hours, leading to certain death unless you stop the process. So we talk about urgencies and emergencies. These are rare, but when they're present, you need to know how to act. An emergency is basically going to kill the patient within a day or two. Okay, so you need to be typically in an ICU setting with vigorous control of blood pressure, but not too low, because such a patient, if you go from 200 down to 120 normal, you lost autoregulation, right? Because you know what autoregulation is, right? Your organ flow and perfusion are maintained despite changes in your perfusion pressure. So here the whole curve is shifted to the right. So you drop your blood pressure down to below 160, you will get brain ischemia, you get eye ischemia. People have gone blind in the setting of too vigorous blood pressure control. So you've got to target just a 25% drop in your systolic blood pressure or mean arterial pressure. And the whole process will cool off. And then after that, you slowly bring them back to your target levels, okay, weeks. And urgency is less emergent, okay. It just tells you that the pressure is high, but there is a situation that can get ugly if you don't act within days. Okay. This is not hours, this is more like days. There's a big list of what are emergent and urgent. Emergent requires reduction quite soon. Urgent is not. You can actually do it in the clinic. Patient has never seen medications and has come in with an urgency. I'll give you some examples. You can start the medication, bring them back in a few days to check them out. Hypertensive encephalopathy we saw is a true emergency. You're going to blow your brains unless you bring the pressure down. A stroke is an urgency. So most patients who have an embolic stroke, we do not wish to lower blood pressure. We actually want to keep it high at 200 because of perfusion issues. A little different with subarachnoid hemorrhage because there's a hole in a vessel that's causing blood to spurt, and we want to get the pressure down, but not too low again, because I'm not sure if you had a neurology, but if you get a subarachnoid hemorrhage, there are vessels that squeeze as a consequence of blood in the subarachnoid tissue, and those vessels will see a further drop in perfusion if you're too aggressive with pressure lowering. So you want some lowering, but not too low. Same with intracranial bleed. Head injury or trauma, you don't want to compromise brain contusion, so keep your pressure in an adequate level. Most people use bolts. You know what bolts are, right? You can measure intracranial pressure, and you measure mean arterial pressure and see the difference. So you want to keep them not too far apart. Acute pulmonary edema is because of LV end diastolic pressure being very high, and that causes backflow into the lung capillary. So you do want to lower the pressure very quickly to prevent this patient from being intubated. Aortic dissection. With each stroke volume, you're tearing the aorta. You really want to reduce the contractility of the heart as your best first step. Pheochromocytoma can be in crisis mode because you're leaking vasoconstrictor catecholamines, right? So you want to block those. Otherwise, the squeeze is going to cause multi-organ damage. Kidney failure, if it's from hypertension, yes, it's an emergency, otherwise it's an urgency. It's a magnifier. Then the eclampsia, which is an emergency in the setting of pregnancy, has to be dealt with very quickly. And again, if you've just repaired your blood vessels, you don't want to see a very high blood pressure. It's an urgency. So you just have to take into account what's going to happen to this patient if we do not control the pressure, and at what level of blood pressure do you wish the patient to be at. So in a dissection, I want to go as low as possible because there's no organ compromise. We're just tearing the aorta apart. So 110, 120 with an IV medication is just fine. But with CVA, embolic stroke or a thrombotic stroke, you don't want to get low on the blood pressure. If it's 260, bring it down to 200. But don't go down to 140. There are certain drugs that you need to know about because they're given intravenously. And they are more or less used, depending on certain characteristics in this population. So there are certain vasodilators. I'll give you an example. So someone has acute pulmonary edema. You want to pull out nitroglycerin. Why? Because it's a veno and a arterial dilator. So it brings down afterload, brings down preload, and the lungs are nicely served. Phenoldipan is a dopamine agonist. So remember, dopamine is an afferent dilator. So if you've got kidney damage, you can use this drug to bring down blood pressure. It won't cause a further reduction in renal perfusion. And there are certain adrenergic blockers. So for pheochromocytoma crisis, we like phentolamine because it's a good alpha blocker, because most of the effects from pheo is from norepinephrine and epinephrine. So you want to vasodilate. And then you can add on a beta blocker to reduce the effects on the heart. But don't use a beta blocker only, because you'll have unopposed alpha constriction and it can actually make it worse. So we'll talk about the last situation, which is pregnancy and hypertension. So this is a young, first-time pregnant woman at 30 weeks. Blood pressure is 160 over 100. There's edema. There's lots of protein in the urine. She gets to go on bed rest, conservative management, but pressure is still high. You just got to know that the safest drug is labetalol. So you can give it oral or you can give it IV. Okay? You could use other agents, but we prefer this drug over other drugs just because of its safety issues. Okay? We should not use any blocker of the renin-aldosterone, angiotensin-aldosterone axis. That's the only thing you got to remember. Everything else is reasonable, but on one end this is completely safe, whereas the other end this is completely dangerous. All the other drugs are somewhere in between, and they should be used only if nothing else is effective. So what is resistant hypertension? You've got 3 blood pressure medications, one of which has to be a diuretic. So do not call them resistant until you've got the diuretic on board. There's a whole list of reasons. You're not taking the blood pressure right. There's too much salt, not enough diuretics. The medicines you're using are not at the right dose. There are interactions. Non-steroidals will cause salt and water retention. Sympathomimetics, ephedra, as a performance enhancer. Some women are extremely sensitive to oral contraceptives. Only way to tell is to stop and see what happens. Excessive alcohol intake. So 1 to 2 is just fine. Shots or doses, okay? You start crossing 2, it's a dose-related increase in your blood pressure. Actually, women do better with 1 to 2. Your pressure goes down. So you could use this as therapy. So to conclude, hypertension is a risk factor. It's not a number. And the higher the number, the higher the risk of bad things going on with the cardiovascular and kidney systems. It's very common, and it's not well controlled. Your target blood pressure, if you need to pick a number, is 140 over 90, maybe a little higher in older people, just because they cannot tolerate a drop in pressure too low. And remember compelling indications, remember contraindications. Thank you. Any burning questions before the class?
sorry. Do you have a spare clicker by any chance? A clicker?
Yes, I did. Oh, okay, yeah.
No, battery.
No, I thought.
You know what? That was me because remember I took it out. I'm sorry about that. Okay. Oh, good. But Joel's got it covered. So yeah, right.
Absolutely. And
and I think
you have
this-
your the flash stick.
No. Didn't I email you?
Yes.
Yeah.
To bring an extra. Okay.
Oh, I have it emailed.
Okay, yeah. Well, but I didn't download it into.
Oh, well, I can just pull it up. Yeah, I mean, if we can just
Why
keep
did
the
he turn
screen
that
down
on?
for a second. Do you